Hello, everyone. My name is Sam Kozen, and welcome to another episode of We're All Patients podcast. Today's guest is someone who is redefining what it means to be a pharmacist in today's healthcare system. Dr. Alice Knotts, PharmD, BCAACP, started her journey at Washington State University, followed by a residency at the VA Puget Sound. Since then, she's worked across rehab hospitals and ambulatory care clinics, always with a focus on improving access and outcomes, especially in rural and underserved areas. Alice has led clinical services, quality improvement projects, and even held leadership roles in pharmacy associations, including president of the Spokane Pharmacy Association and a board seat with the Washington Rural Health Association. Now at Cornerstone Whole Healthcare Organization, she's tackling some of the toughest challenges in public health, from opioid use disorder to harm reduction and STI care. Alice, so excited to have you here. Welcome to the show.
Thank you. Appreciate it. Excited to be here.
So you and I have a lot to talk about. There's a lot of myths and misunderstandings and fear and so on that we have to address. No pressure. So I was thinking to start with the first point that we have on our podcast intro post, and that's, seems like a pharmacist is a doctor who specializes in pharmaceutics, clinical pharmacology, and therapeutics.
Yeah, I mean, to put it in terms that other professionals can understand, right? To say, like, what are we specializing in? Why do we feel, I guess, entitled to call ourselves doctor after 4 years in graduate training, medical training? Pharmacists are feeling entitled to call ourselves doctor, but the rest of the world is like, no, you're not a doctor. You're not a doctor. That seems to be the ongoing thing. So it's like, okay, well, we need to explain, what our training is, what we're learning, and why do we feel entitled to do this? So yes, those are the things that we are, why we're specialized, why we are, what we're doctors in.
So in that capacity of therapeutics,
Yes.
what is that? I mean, that's a big, loaded term.
Yes.
What does that even mean?
So basically, the management of patients, usually in our case with medications, right? Treating patients with medications, pharmacotherapeutics. But there is this misconception that pharmacists are going to push pills on people, right? That's where pill pushers. But that is so far from the truth. Once you become a medication expert, if you learn anything, it's that medications are often not the solution, right? If anything, we learn that you get too many medications on, you just end up piling more medication. One medication leads to a snowball effect. You get another and another and another. It's like, no, let's try other options first. It's guideline-based treatment. Like, usually non-pharmacological approaches are our first line option. So we are trained to the nth degree in guideline-based care, right? In how to do non-pharmacological approaches first. So it's therapeutics, right? It's not just medications. It's the full treatment plan. That's why it's not just pharmacotherapeutics for pharmacists. And our training reflects that. We are being trained in all the things to treat patients. Sans surgery. I will not touch that with the 10-foot pole. But within reason, we everything to treat a patient on the treatment side of things. That is what we are trained in. Therapeutics.
So with that, I can feel people from like the AMA or doctors in general being having the feeling that you're encroaching in our space?
Yeah. That's understandable.
So what is the goal? Is your goal to encroach on their space, or what's the goal here?
No, the goal is, so there's too much information in the world in the medical field for any one professional to fully understand, right? I feel at this point that anyone working in any field can agree that there's about, depending on how you categorize it, about 19,000 categorized diseases out there. That's more than any one human could probably rote memorize, let alone know the differential diagnosis and understand that process for all 19,000 diseases out there. And on the flip side, there's about 14,000 approved medications out there, FDA approved medications, let alone supplements, let alone those drug-drug interactions, let alone all the adverse events or adverse effects that come from the medications. There's more information about medications. Actually, there's more information about one medication out there. There's a guy who wrote his PhD thesis about one medication. He spent his entire postdoctorate training or his doctorate training writing about one medication. I can't remember. It was like colchicine or something, an old school drug. That's insane. So why not let us live in our respective areas and really become experts in those? There's crossovers. There's 100% crossover, but we need experts in diagnosis and to really delve in and understand the complexities of the differential diagnosis. And we need experts to really understand the complexities of medications. And we have to have both those experts understand the crossover in order to be experts in their fields, right? Physicians need to know how to prescribe, and they need to know teratogenicity. They need to understand drug-drug interactions at least a bit in order to avoid patient harm. But we need the experts over here really managing the meds to optimize, to get patients to goal, to if we want to have a fully functioning system, why not have a whole body of experts who are trained to be experts actually managing that side of things? And those experts, because we realize you can't operate in a vacuum, you can't operate in a silo, also have now been trained, and since about 1965, have also been trained in diagnosis, because we can't just realize you can't just know medications. You have to know how to diagnose. And there's very complex training and processes that have been developed on the pharmacy side of things, on the pharmacist side of things, to understand how to diagnose within our specialty. And it's not the same as physician approach to diagnosis. There's overlap, but it's not the same.
So I think it's actually a great thing you brought up, because that's where the statement from the AMA we'll get into later and things like that. That's kind of when I think with physicians hear the word diagnose, they assume you're talking about like what they do, right? That's like the when MD make decisions, you diagnose, you treat the patient based on that, or you look at the patient and then you are able to diagnose them based on your knowledge and experience. So I feel like that's maybe part of the issue, is that diagnosis is perhaps a broad term that you see as a more specific kind of niche that you are looking at, versus like the whole meaning of it.
Yeah, it turns out it's not a one size fits all.
Okay.
Turns out, even though, I mean, we're saying the same words and we are doing the same, it is diagnosis of diseases, right? But it's coming from different angles, different different areas of expertise. In the physician realm, right? And I correct me if I'm wrong in stating this. I view your area of diagnosis as you have every disease out there, all 19,000, and you have to narrow it down based on the differential for whatever your prime suspect is. Where from the pharmacist standpoint, we are looking at, so we have basically two arms that are within our specialty. One is the retrospective diagnostic review, which is, if you were sort of, an analogy would be if we were on a baseball team, the physician would be the pitcher and the pharmacist would be the catcher. If in healthcare, the only person, the only individual, once you throw that ball, once you throw a diagnosis into the air and a prescription, the only one catching it is the pharmacist. There's no one else on the other end, right? So if the prescription's is wrong, dose, whatever drug, doesn't matter. The only one that will catch it is the pharmacist, if it's catchable, right? Same with the diagnosis. And if the diagnosis doesn't match the correct indication for the medication, right? That's the pharmacists have realized that is extremely important for patient safety. And once, as the shift from, the product-oriented care to patient-oriented care occurred, pharmacists realized immediately how important it was to ensure correct diagnosis for medications. And so you can't rote memorize something like, oh, hyperlipidemia, okay, it matches the statin, okay, we're good. Like, no, we have to go and check lipids if we have it. Like, we need to go and make sure that this patient does it actually match. For example, the other day in clinic, I had a clinician reach out to me and he said, I have this patient, CKD stage 3B. Will you renally adjust his meds? All right, okay. Well, let me go in. I'm in a clinic. Let me go in and let me look at the labs. What does that mean? I have to, look at his meds, et cetera. And I saw one lab value in there. Creatinine clearance was like 43 or 49 or something to that effect, but there was only one lab value. I was like, well, that's not CKD. That's just one lab value. And I knew, I was like, okay, it has to be consistent over time. Couldn't remember exactly how long over time. So I looked it up. Okay, it's like you need at least 2 lab values over 3 months. All right, well, let's go see what else we have. I found another lab value back in December for the EGFR was 90. I was like, well, okay. And then I also was digging through the meds and he had ketorolac on recently. I was like, well, this definitely could be an AKI. This could be some sort of, acute kidney injury. So I'm like, okay, I'm just going to sit tight. There was a lab that was going to result that day, which would have been a month from the most recent one. Wasn't going to technically diagnose CKD, but it would at least give me a trend. And then I could have a conversation with that clinician. Say, we probably shouldn't do any renal dose adjustments, but we could at least make some decisions, especially if it was like significantly more impaired or something like that. Maybe we could hold some meds. But it came back, shot right back up. EGFR was 90. Sorry if I interchanged creatinine clearance and EGFR. It gets confusing since we renally dose meds based on creatinine clearance, and then everything else is EGFR. Anyways.
I understand what you're thinking. So you're saying that his creatinine clearance shot back up towards normal, and so you weren't as concerned with chronic disease.
Right. So it wasn't CKD stage 3B. So, I was told I was told the diagnosis, but it turned out to be just acute kidney failure. Not the diagnosis, but I was able to check. And, what if I had gone in and just renally adjusted all his meds and sent him along his merry way? That is just an example why pharmacists realized as soon as we were integrated in patient care, as soon as we went this way, that we're like, no, we can't just take things at face value. We need to be able to cover ourselves clinically, and physicians, just to make sure that we're having proper communication. Because who looks the worst if I had just renally adjusted all the meds? It would have been the clinician, right? That it would have reflected back on that person. So go ahead.
No, yeah, I was just going to add. I mean, right. So I think that's what physicians are essentially concerned with, is that there seems to be a lot of scope creep from different angles, and they're afraid that the person that's most accountable, or essentially in the clinic, or the person who gets sued is the clinician, is the doc. So they're afraid with, look, well, everyone else, the PAs and Ps, let's say pharmacists, have more scope, but then the person that's going to get sued is a doctor, or as a medical doctor, and so like, how is that fair, essentially, right? Because it's like, that's not, if they're going to like, I still have all the responsibility, all the risk, and so of course, like other specialties or other professionals can take on more responsibility, but they have the safety of knowing, okay, well, the medical doctor is the one that takes ultimate responsibility for it. So
yeah, and that the lawsuits and I don't know how best to speak to that sort of thing. I do feel like the legal system in the country and how it's unfairly targeted physicians is definitely detrimental to patient care, right? Don't you pay like an absurd amount for
absurd amount is probably on the low end if but
for your malpractice insurance? Yeah.
So I mean, so personally, I don't practice, so like I'm internal medicine dropout. So to me, my goal is to help the healthcare system improve and get better. And since we're all patients, that means that they can improve, if it improves for all of us. And but yeah, the physicians do face a lot of responsibility and so on. And part of that is, so I think it sounds like what you're saying is you're there to help them decrease that risk versus increasing it.
That's correct.
You're kind of like a bodyguard almost, or like like you're saying, the catcher, where you make sure that in the team setting, that the patient gets the treatment that they need, and you're kind of not a second opinion, but essentially a second set of eyes that looks at the orders, or the medications the patient's on, etc., and essentially just make sure that like everything looks good. And if you see any issues, you talk with the physician about it to make sure that the patient is taken care of.
Yeah, it's the ultimate, team-based care, the ultimate collaboration. It's a writer with an editor. It is the pitcher with a catcher. It's so the physician is no longer having to be on his own. That you can't be perfect all the time. No one's perfect all the time. At least one study showed that about 1 in 20 diagnoses were incorrect. And I don't know your perception. Usually when I say that, most physicians are like, that seems low. It's usually, but right? But think about like that second set of eyes looking at it from a different angle, from a different training, from a different perspective. It's not gonna be perfect. We're still human. Maybe AI will come in there and be that third set of eyes, and then maybe we'll be perfect. But it allows for this nice synergy to help patients stay safe and to help physicians make the best choices for their patients, especially when they work really collaboratively together, right? When the system works really well together. And that's the purpose of that retrospective diagnostic capability with pharmacists. Now, is that the only capability for diagnosis? Absolutely not. We have the diagnostic skill set, right? We're able to diagnose. We have the training. And in particular, when you look at traditional diagnosis styles, one that is really overlooked is when it comes to medication effect, right? Medication effects. And like the World Health Organization, I think they estimated maybe 1 in 30, give or take, patients likely have harm related to their medication because of misdiagnosed medication effects. They also say that number is probably really low because of lack of monitoring, lack of recognition, which, I mean, it's misdiagnosed, so lack of recognition, right? And in my opinion, lack of allowing the experts who are trained to recognize those conditions as being allowed to be leaders in recognizing those conditions. And by experts, I mean the pharmacists. So we have, like, our entire training is set to be able to recognize those in a very complex way, and from patient interview skills to our knowledge base. We receive 3 solid years of didactic training, and that didactic training includes all the skills to really narrow in and figure out how to diagnose everything related to medications. Everything. There's such a huge knowledge base out there. And without that knowledge base, the diagnostic process is it's going to fall short, right? So I have this whole chart that I put together with how we go through all the way from, starting with, is the condition the patient feeling or experience even a likely possibility from the medication? And then, is it new onset? Is it an onset of, is it unknown duration, intermittent, or long-standing? And then you have 2 different columns you go down. And then you always think through polypharmacy, adherence, and then you can you go through and you think through lifestyle factors. And then, at the end, you always have to consider, is it not the medication? Is it a disease? And then it brings you to the other side of the traditional diagnosis. You have to go through the same process that physicians go through to think through, that side. And possibly, do you need to refer them to a true diagnostician for diseases? And then, you make your differential at the end. I know that's a lot of words, but the point of the story is we have a very complex process that we go through to determine if a medication is causing harm to the patient, which medication it is, and those are being under-recognized, and probably costing a lot of money and causing a lot of harm to patients.
Well, when you talk about all this, I'm just thinking of So you and I have talked about this just in our previous conversations, but the average physician, if they have, let's say, a panel of 100 high blood pressure patients, they're only controlling or are able to bring about 50% of those under control. And it's not that different for diabetes or like CHF or other chronic diseases. They're all plus or minus that. Some are, some rates are lower and so on. So I've seen doctors who, following algorithms, have increased that to like in the 90+%.
Yeah.
So I wonder, it seems like having a pharmacist on the team, for example, let's say treating, the patient, the doctor, the medical doctor diagnoses the patient with high blood pressure. And then the pharmacist seems like they would be better suited to then follow algorithms to get a patient under control, and then thereby freeing up, the doc to, or the medical doctor to see other patients like like acute things and so on, versus having to task themselves mentally with having to figure out how to get this patient under control.
Yeah, and I know we had touched on this. Yeah, that pharmacist, part of our training, and not part of training, at the core of our training, and part of the reason we spend so long in didactic training, all 3 solid years in didactic, which was I found really annoying. Not annoying, but we spend so much time learning book knowledge, right? Like, but because there is so the essence, the core of what we need to know is just this giant knowledge base of how drugs interact with each other, the clinical trials, everything about medication. Well, not everything. So much about medications relies on understanding the guidance, the information behind it, that we are heavily trained on guidelines. And what are guidelines? They are, in essence, a defined, often based on defined algorithm of how to treat patients. Like, what is the best way to treat a patient? And typically it boils down to an algorithm at some point. You do this first line, you do this second line, you do this when it comes to the medication process. So much of what we build and how we treat patients is built on algorithms that pharmacists are really, really, really good at managing to efficacy. That is the goal, to manage to efficacy. That's how we train. And so there are so many studies out there demonstrating that when you put a pharmacist on a team or by themselves to manage chronic disease states, hyperlipidemia, diabetes, hypertension, that patients' outcomes significantly improve and save money, billions of dollars, because pharmacists are so good at doing that just based on the nature of our training. So medications and like medical knowledge around medications is literature heavy, right? Whereas physician knowledge, disease, differential diagnosis, that kind of thing, requires a lot more hands-on. Like, I think you can have and again, correct me if I'm wrong here, but this is how I imagine like differential diagnoses and that kind of thing. And the reason why you receive fewer didactics in medical school is, okay, you get 2 years didactics typically, and then they kick you out and say, go have fun in clinic, right? Clinical, it's not exactly like that, but sorry, go ahead.
No, that's a funny way of putting it. Yeah, it's 2 years of just classroom and book learning and so on. And then the other 2 years are essentially, like you said, clinical rotations where you're learning from hands-on, but also your preceptor or your attending docs essentially, like whenever you see let's say you see a hypertensive patient, hypertensive emergency or something like that in the ER or in the hospital, then you have to, the next day you're essentially going to, they're going to ask you questions like about that condition. And then the night before or that night, essentially you read up on hypertensive emergencies and so on. And then when you get grilled the next morning, that you are up to date on it and you don't get embarrassed in front of the other medical students and so on. Right. Anyway, so yeah, go ahead.
Okay. Yeah, that makes sense. That's kind of, clinical rotations, how it kind of works. Okay. So with the, with diagnoses as like the forefront, right? You could see 60 pictures of whatever, let's say, I don't know, what's the condition that you need pictures of to diagnose or something?
Different, let's say, cancers or like, who's looking at histology or, for different tissue samples or like, cancer would probably be a good one.
Yeah, cancers or maybe even a condition you can't really get good pictures of, right? You need to be there. You need to touch them. It doesn't matter how many pictures or how it's described or whatever. It's that experience when you're there in the hospital. It presents differently. It never looks like the textbook ever, that kind of thing. Like why the clinical experience in the diagnostic realm is so forward in the MD student curriculum. It makes so much sense because if you're going to be a diagnostician, like a true expert, you have to see the variations in order to start putting together those pieces, like, right? Which makes sense to me. Whereas on the pharmacist side of things, we need the clinical reasoning skills that come with this huge database of these algorithms, of the knowledge that goes with how best to put together one drug that somebody could write a PhD thesis on that has 600,000 drug interactions with every other drug out there. And how do you have that at the tip of your brain with all the little red flags and spiny senses that go off when you see that with 14 other drugs? And all the little things that are going to go off at the right period of time so that you make your correct diagnosis and you pick out the right thing that actually is a red flag and not just I think it's probably okay, and you send them out the door, right? So it's very much more of a internal process and intellectual process more than, because there's nothing I can necessarily that I'm going to see on the patient. You definitely can see things on the patient, but it's more of questioning, using the right line of questioning, histories, presentation, research, focus to determine which medication or what the errors are and that kind of thing forward in pharmacy than it is in like diagnosticians. But there's overlap. You can't have one without the other, but it's just like in our individual areas of expertise, one is more forward than the other.
So it sounds like, for one, you're not trying to advocate for pharmacists having their own clinics and essentially, being medical doctors by themselves.
So that's two separate questions.
Okay.
A pharmacist could absolutely have their own pharmacist clinic. Pharmacist clinic. Think about a clinic pharmacists put out there, and they manage diabetes and hypertension, and they get patients to goal, and they are 100% capable of doing that within their training, and they could have some really great, we could have some really great control out there. And pharmacists are more than capable and more than trained to have their own clinic. But really, we should all be working together. Like the yin and yang should be there, right? Like physicians, I mean, are also more than capable of having their own clinic, right? They are. But really, the yin and yang should be there. Like we should be working together. What I don't want to say is like pharmacists can't do this. Physicians can't do this. Like let's not say that. But we should be working together. It should be.
So you're trying to complement essentially each other for the sake of the patient rather than like have a turf war as far as who can do what.
Yeah. Yes.
So ideally, what would that look like to you? Like I know, and we've kind of talked about that, but like just if you were to lay out like your perfect vision of how things would work.
Ooh, perfect vision, man. That's a great question. Do you have an idea? What's a perfect vision?
Mine? Mine would simply be for every patient to feel like they're valued and taken care of, and they're given the time that they feel understood, and that they can see that their disease is under control. Let's say, again, like just chronic care, chronic diseases, just diabetes, high blood pressure, cholesterol, you name it. Like, patients shouldn't be poorly controlled on that. I know we're talking, look at social determinants of health come into play, et cetera, but really, I've seen for myself where literally with following algorithms and with the proper patient engagement and clinic setup, 90 plus control rate of high blood pressure, which is like unheard of in Dayton, Ohio, of all places. So to me, it's simply like, okay, well, we're all professionals here. What can we do to essentially get the patient the best treatment possible, the best experience possible in the lowest amount of time, and obviously without astronomical cost involved as well. So to me, like it's like what you described to me, and this is going to be ignorant because I'm kind of going to summarize your points into so that they're going to be missing things. But essentially, you're looking for ways to just work together as a team, regardless of kind of like, it's like you want to, let's say you would be getting together with a physician to say, okay, here, like, scratch everything we've done before. Like, let's plan a clinic and where you can, where we can work together to get patients the best treatment. So let's say, you can lead a team that when the patient comes in, you can diagnose them, figure out what's going on, and start the medications that you want, or feel most appropriate to the best of your ability. I will then be there to, because I have to, because you as the pharmacist have the benefit of essentially like, hindsight's 2020 almost, right? Where it's like, you have now the benefit of being able to go back and see, okay, now I have more labs, I have more information, etc. And now I see how the medication has been affecting this patient's conditions and so on. I can then go back and see, okay, if this is appropriate or not, and better adjust what they're on to meet their needs. And then they can come to me for, like I can kind of see how they're progressing, manage their side effects, etc.
Yeah, that would be a great model. It would be a great model and pretty efficient too, right? For the follow-up. yeah, the pharmacist could just be there for that follow-up check to make sure the meds are working appropriately, are interacting, or prescribed initially appropriately. There is a possibility that that initial fill wasn't ideal, but it still would be a pretty efficient process, I would think. Yeah, I think that'd be great.
Okay, so that sounds like, we'll see if we have any what the comments are on that idea. But otherwise, okay, so what about when was it appropriate for the pharmacist to to actually do the to see the patient initially and make the diagnosis? Are there instances where it's more appropriate or as appropriate for them to do it versus a medical doctor?
The initial. Yes, definitely. So there are pretty much every patient out there, pretty much except for a few young bucks, have been in to see a PCP at some point, right? They're on medications. They're on something. They have questions. They have concerns. They have side effects. They have a diagnosis that has been made, right? And from that, management can be done. Also, pharmacists, we have pretty much for every, for most specialties out there that there are physicians, we now have specialist pharmacists. I guess maybe the, sorry, let me collect my thoughts. Let me make sure I'm understanding the question.
Sure.
So the question was, when would it be appropriate to see a pharmacist first versus a physician, right? So defining the question a little bit better. So the patients have almost always seen a physician first, right? Unless it's an urgent care setting for a problem. Does that seem correct?
I would say that, yeah, they mostly see a physician first. And now these days it could be an NP or a PA.
Yes.
But yeah, in essence,
yes.
Right. That's typically the first, let's say I have a cold or I have cold symptoms and I want something for it. I can either go to an urgent care, or if I'm lucky, maybe I can squeeze in, today with my primary care physician or someone else. Yeah, I'll go and see what, hey, this seems like a cold. Is it something more serious? Sure.
Yeah. So let me talk about the urgent care kind of situation. So there have been pharmacists and pharmacies that have had kind of this business model of an urgent care light, if you will, is kind of what they're calling it, where I don't really like this term because I think it's misleading, but they monitor, or they address minor diseases and conditions at the pharmacy, typically by protocol or collaborative practice agreement, depending on the state and the model. Urinary tract infections, strep throat, things with CLIA wave tests, that kind of thing. So to offload burden and wait times and that kind of thing, they'll just come into the pharmacy, and often the pharmacy will have the list of things that they will see and test for, respiratory illness, that kind of things. Like, you have these symptoms, we'll see you, that kind of thing. So those models have come up as an access to care. I mean, there are, I was reading an article on vulnerability indexes and for pharmacies. And in that article, it was saying that there's communities out there, like rural communities, one of my passions, that their only access to healthcare in the entire community is a single pharmacy. That's it. Otherwise, they're driving to the next community. And a lot of them don't even have, access to transportation is a significant issue in these communities. So if the pharmacy doesn't step up and provide some of these services, they just don't have any services, right? So let's expand some access to care within the pharmacy. So that's an instant, right, for just some of these minor things. Now we're moving on beyond that. When we're talking about, so this is not necessarily like a direct collaborative relationship where physician sees a patient sees a physician or other provider like a physician, like an NP or a PA first, and then a pharmacist, like directly, like a direct relationship like that.
Sure.
We just have a patient come to a pharmacist clinic, let's say like that, and they're like, hey, I want to see you. I want to see a pharmacist. And the motto would be, the pharmacist says, great. Where have you been seen before? Just like any other clinician, let me get all your records. Let me see all your diagnoses that you have. Let me see all your labs. Let me see all your current medications, right? Let's see what needs to be addressed from my expertise standpoint, right? Mm-hmm. So you have hypertension and you are on 3 blood pressure medications. This is just a scenario. Like, my blood pressure isn't under control and I'm on 3 blood pressure medications and I don't know what to do. Can you see me? Okay, right? So you get all the records in from the other clinics, you see them, and then you talk to him and you just find out he just takes it as needed. His blood pressure medications, right? So then the pharmacist.
That's so unusual, right? Yeah.
How odd. Exactly. So then the pharmacist talks through, okay, let's get a pill box and let's start taking it at, and then it turns out he only needs 1 blood pressure medication, and then we move on with the rest. No, but and then that's an appropriate use of a pharmacist clinic. If there's pharmacists are, this is one thing I want to point out, because this would be a fear of any non-pharmacist clinician. What happens if there's red flag symptoms, right? What happens if he shows up and he's got numbness in his arm and pain, like, what's the pharmacist going to do? We're generally not trained in emergency medicine. There are emergency medicine pharmacists, right? But I'm not going to be doing an EKG in clinic typically. I did get training on that, but I'm not going to, probably not going to be doing it. So, but what we are trained very, very well on is how to recognize red flag symptoms and how to get them the appropriate care they need. Triage and appropriate care, right? Okay, let's take his blood pressure. Oh my gosh, it's 190 over 120. I'm calling an ambulance. We're getting him to the appropriate place, right? So this is something that we have been trained to recognize how to triage where this, like, what kind of referral is needed based on symptoms. Like, what is within our scope? What should we address as clinicians, and what should another clinician address? So go ahead.
So you're not about to hang a shingle in that rural town where there's no physicians to be, within a 30-mile radius or more. Like, your goal essentially is to, it's kind of like, reminds me of one of my guests is a doctor in rural America, I think in Tennessee, and he mentioned something. This was about hospitals, but he's like, comparing when you benchmark rural hospitals against, let's say, like big academic medical centers, that's apples and oranges, right? They're not going to be like centers of excellence in like something, like spine care, or maybe, potentially even maybe a stroke or heart attack, or whatever metric that, you want to use against some random place. It should actually just be against, like, hey, how are the outcomes in the area compared to nothing? Yeah. As in, if that hospital goes out of business or is not there, what does care look like then? because that's more accurate than trying to, like hold the big academic medical centers, as a comparison to these, 20-bed hospitals in the middle of nowhere, because they don't have an academic medical center to go to. That's the whole point, right? It's essentially that or nothing. So the scenario you're describing sounds like also it's okay, well, you're essentially taking care of the people who literally have no other choice. And you're providing them with care that you're managing them. You're not trying to take over a physician's role in managing the patient or trying to diagnose, etc. You're simply providing care where there is none to be otherwise had.
This is a gap, right? This is something that physicians aren't necessarily trained in to do this long-term chronic management, high touch, right? These are often patients that require long periods of conversation in order to figure out what's really going on versus just like
they never just have one concern.
Let's take the hypertension patient that had 3 meds, right? Blood pressure high, let's give you another blood pressure med. Blood pressure high, let's give you another blood pressure med. When the time was needed to really figure out take the time to do the right questions to figure out, oh, he just wasn't taking it as he was supposed to be. Okay, so now let's get a new game plan where you take it as you're supposed to be, which, you think would be simple, but asking the right questions and really getting the right answers is much more complex than you would think. Patients don't like to divulge information that makes them look bad. And sometimes they don't know that's information that's worth divulging. So pharmacists we're trained so well in how to just tease that information out of patients, because and again, that's why we spend so much time in training and developing those particular clinical skills.
So in the AMA article from February 5th of last year, one of the things they mentioned in there was essentially, well, hey, aren't pharmacists busy too? Like, when are they going to have all this time to talk with patients?
Yeah, I love that they brought that up, because there's an issue in pharmacy where we have been relying on our income for our jobs from products, right? But we're being trained in patient care. We're not being paid for patient care. We're still relying on these products. And I don't know if you've heard of like the PBM issues, where these third party entities, middlemen, yes, middlemen are taking money away from community pharmacies. They're originally supposed to protect consumers, but now are essentially harming them, and also making it so pharmacies are going out of business and really can't make any money. So because of that, because we can't get paid for patient-oriented care, they're essentially stuck working to the bone, right? That's why there's no time. There's no time to do patient-oriented care. There's no time to do anything, because they can't make any money in that space. But should we actually recognize pharmacists' skill set, right? Let's recognize pharmacists are trained to be doctors. They're trained to be specialists in this area. They have so much to offer patients in the healthcare system, save money savings to the entire healthcare system. And you can look out there, there's many, many studies showing how much money pharmacists, should they be utilized appropriate, can save the healthcare system. Should that be taken into account, and now we pay pharmacists to do the clinical side of things, right? Then they can quit working to the bone. They can focus on the patient care. They can focus on the savings to the system by providing that excellent patient care. They can save physicians money and time by, decreasing the risk to them, right? By stopping inappropriate interventions, inappropriate diagnoses, as as appropriate, not inappropriately, not annoyingly, just collaboratively. Yeah.
That reminds me of, so I've been reading a lot about project management, for instance, and in project management, or like in critical chain project management, and then, or essentially, which is part of theory of constraints, there are concepts like having full kit, which means having the tools to do what you need to do, not having to like go search for them. But also like dosage, meaning like instead of just having seen it, if I only have time to see the patient for 3 minutes or 5 minutes and say, okay, well, your blood pressure is still high, I'm going to increase your dose. And the patient's like, should I tell them or should I not tell them that I take this like whenever I get a headache for my high blood pressure versus actually taking it every day, just when I'm supposed to be, or I can't afford my medication, or whatever it is, like. But so when you have a low dosage, meaning like you don't have a lot of time to spend with the person or to go over their condition and the things that are going on, that's going to cause you more work over time, because they're going to get sicker, and then you have to just spend more time with them. Versus if you spend a little bit more time with them initially and get them better controlled, that's going to result in them not coming back as often or needing as much time in the future because they're well controlled. So that's one of also kind of things of like, if we have better quality in in controlling and managing chronic diseases, that goes a long way to actually freeing up time in the future and addressing the provider shortage and so on. And so with pharmacists being able to do that, I mean, provide that time essentially, that helps everyone kind of like take a breath, and being able to then like with time, it's like, whoa, I'm not seeing as many patients a day, and then my patients are healthier, and I can see more acute patients, let's say, whatever it is, I can do other things with that time. But yeah, I don't really see. Granted, I mean, there's always ways to take advantage of different things, but like and misaligned incentives. But overall, from what you've said, I don't see any, really any big negatives as far as how any of this would hurt doctors, or I mean, like medical doctors or pharmacists or the patient.
I mean, there are, and we're getting low on time, so I don't want to open up a bunch of can of worms. There are definitely lots of arguments out there, both for and against pharmacists being allowed to do what they're trained to do, is what it comes down to. So pharmacist training has increased in basically since the shift from product-oriented care to patient-oriented care. And then since the requirement of the PharmD degree in the early 2000s, we've really just been elevated to this level of care, or this level of clinical ability. But then maybe we haven't brought along with us the rest of the medical community. And we haven't really found a good voice, a way to articulate it to the rest of the medical community, what we can offer. This is a good start. Thank you for having me on. I really appreciate it. And I'm working on finding good ways to articulate, and I'm still trying to figure out, it sometimes feels like I'm speaking a different language too, right? But hopefully we're starting to get there.
Well, yeah, I appreciate you, spending your time with me, and you're welcome back anytime if you have any updates, or we'll continue the conversation. I know we have lots to talk about still. We covered just a fraction of the things we were thinking about. So thank you everyone for tuning in. Till next time. Thank you. See.